Thank you for inviting me to give you a talk about advanced non-small cell lung cancer targeted therapy in non-ALK and non-EGFR mutant non-small cell lung cancer. This is Erminia Massarelli. I'm Associate Clinical Professor, Chief Thoracic Oncology at City of Hope. These are my disclosures. So non-small cell lung cancer is subdivided in different subcategories according to potential for targeted therapy. So the most frequent gene alterations, EGFR, followed by KRAS, 25%, ALK, 7%. Then we have less frequent mutations such as BRAF, fusions such as ROS1, RET, NTRK1, MET, MAP kinase, PI3 kinase, and others. But we're going to talk about first RET fusions. RET is a rare driver of multiple diverse tumor types. Most frequently mutated RET is medullary thyroid carcinoma, followed by papillary thyroid carcinoma, 10% RET fusions. And then non-small cell lung cancer has RET fusions in about 1 to 2%. So RET can be rearranged with different fusion partner, such as KIF5B, which is the most frequent, and CCD6, which is the less frequent in exon 12. There are several multi-tyrosine kinase inhibitors, such as Regorafenib, Lenvatinib, Alectinib, Cabozantinib, Ponatinib, Sunitinib, Sorafenib, and Vandetanib. However, they are not specific RET inhibitor, and their potency varies, as you can see in this table. So Selpercatinib LOXO-292 is the first RET-specific inhibitor, tyrosine kinase inhibitor, that was shown in the clinical trial Libretto-001 to have efficacy in RET-fused positive non-small cell lung cancer. In this trial, which was a phase 1/2 trial, it was presented by Dr. Drillon, published in New England Journal of Medicine 2020. It enrolled 144 patients with RET-fused non-small cell lung cancer. 105 were previously treated with platinum-based chemotherapy. 39 were previously untreated. The response rate was 64% in previously treated patient and 85% in previously untreated patient. And 12 out of 531 patients in the overall cohort, so 2%, discontinued because of drug-related adverse events. The median duration of response was 17.5 months. So in this waterfall plot, you see on the left side, you see the maximum change in tumor size in patients with previously treated. And on the right side, you see the all-target lesion in previously untreated patients. So to go back on the left side, you see in the blue bars are patients who were previously treated with checkpoint inhibitor, either anti-PD-1 or anti-PD-L1. In the light blue are the patients who did not have any checkpoint inhibitor exposure. The asterisk represent previous multi-target kinase inhibitor. In this panel B, you can see the intracranial target lesions in previously treated patients. And you see that there was 3 complete responses and several partial responses. In this panel C, you see all target lesions in previously untreated patients. The median duration of response was 20.3 months. At 1 year, 68% of all the patients were progression-free. The median progression-free survival was 18.4 months. Here you can see the panel A is duration of response among patients with a response, and B is the progression-free survival Kaplan-Meier curve. Another specific RET inhibitor is Pralsetinib, or also named Blue 667, that showed in the ARROW study, which was a phase 1 trial in RET-positive advanced non-small cell lung cancer, efficacy. So patients were treated starting 400 milligram daily. In total, there were 120 patients, and 91 of them were previously treated with platinum therapy. Here you can see Patients had several previous lines. The median was 2 lines of therapy. 77% of them actually were exposed to chemotherapy, about 40% to prior anti-PD-L1 inhibitor. And here is the waterfall plot. So the response rate was 58% in all patients, 60% in patients with prior platinum exposure, and disease control rate was 96%, respectively, and 100%. 5 out of 7 treatment-naive patients had confirmed partial response. About the safety of RET inhibitors, here you can see on the left there is a very detailed table of the Selpercatinib toxicity profile, and on the right of Pralsetinib. So you see that the most frequent grade 3 or higher adverse events were hypertension, increased LFTs. There was about 30% for Pralsetinib to have LFTs increase. You can see hypertension, hyperphosphatemia. So these are the ones that you may encounter to have the highest frequency. Now let's go to NTRK. So TRK fusions are found in diverse cancer histologies. There are some common cancer with a low TRK fusion frequency, such as lung cancer, but there are also some rare cancer with high TRK fusion frequency, such as salivary cancer, for example, the mammary analog secretory cancer and the secretory breast cancer, and some infantile fibrosarcoma and congenital nephroma. So larotrectinib development started with some cohorts in adults and pediatric patients, and adult and adolescent patients that included a total of 55 patients. And basically, you can see here the waterfall plot that shows significant responses in different types of, so independently of the histology of cancer. Here you can see the lung cancer in blue, this light blue, and the partial response was 64% respectively in the patients with confirmatory response that are available. The objective response rate was 76%, stable disease 12%, progression of disease in 12% of patients. So this is an integrated analysis that was done across phase 1-2 trials of Entrectinib, including the ALCA trial, the StarTrack 1 and 2. And there were a total of 54 patients, 12 with CNS metastasis and 42 without CNS metastasis. And the safety population, so the safety results were on 68 patients with NTRK fusion positive receiving Entrectinib, and overall in 355 patients receiving Entrectinib independently of the fusion. Here you can see that the non-small cell lung cancer group is actually in blue. And so this is the waterfall plot, and the objective response rate in NTRK fused patients was about 57%. This is all patients, 54 patients. In the non-small cell lung cancer NTRK fused patients was, which was 10 patients, it was 70%. So there was one complete response. The median duration of response in the non-small cell lung cancer cohort was not reached, and the median progression-free survival was 14.9 months. The overall survival median was not reached as well. So about the safety profile, this is the larotrectinib on the left panel and the Entrectinib on the right panel. You can see that basically the grade 3 or higher toxicity are very minimal, mainly LFTs increase, dizziness, nausea, anemia, decrease in neutrophil count. However, you can have in any grade of toxicity for most frequently, I would say, it would be fatigue, vomiting, but they were not significant. As well as for Entrectinib, the toxicity profile was very well manageable, and grade 3 or higher was mainly weight gain, anemia, fatigue, and some peripheral edema. So larotrectinib and Entrectinib are effective inhibitors and approved for NTRK-fused tumors. They have CNS activity, and currently there are more drugs in development. So response rate, just to remind you, was 75% for larotrectinib, 70% for Entrectinib, and the dose reduction actually was pretty low. So safety toxicity profile was manageable. So for the BRAF targeted therapy, so we have two different drugs. One is Dabrafenib, so BRAF specific inhibitor of the mutation V600E and 600K. Dabrafenib and Vemurafenib. In particular, Dabrafenib is a reversible potent selective inhibitor that synergizes with Trametinib, which is a reversible, highly selective inhibitor of MEK1 and MEK2 kinase activity. This combination has been based on synergy because the BRAF inhibition can have an escape mechanism in MEK1 and 2 and ERK eventually. So therefore, there is a rationale for the combination of these two drugs. So these two drugs were combined in trial BRF 113928, which showed in 84 patients with BRAF V600E non-small cell lung cancer patients, a response rate of 33%. And in the cohort, the second line cohort, so patients previously treated, the response rate was 66.7%. In the first line cohort, the response rate was 64%. The median progression-free survival was 10.2 months. So for the safety results, the grade 3 for more frequent serious adverse events were pyrexia, vomiting, rash, dyspnea, hypotension, and some cytopenias. For example, skin rash is one of also the side effects. Now let's go to RS1. This represents alteration about in 1–2% of non-small cell lung cancer, mainly adenocarcinoma, but also pleomorphic carcinoma with solid pattern adenocarcinoma, and they have a specific histologic signet ring alterations. They're mainly present in women, non-smokers, and RS1 is detected by immunohistochemistry with FISH confirmation or PCR. So the clinical trial showed Pralsetinib efficacy in RS1 rearranged non-small cell lung cancers, profile 1001. It showed that median overall survival of 51.4 months, response rate of 72%, median time to first tumor response was 7.9 months, and median duration of response was 24 months, with median progression-free survival of 19 months. So the safety profile in RS1 rearranged patients was pretty mild. So basically, only grade 3 toxicities recorded were vomiting, elevated transaminases, hypophosphatemia, neutropenia. So there are several other RS1 inhibitors, such as Entrectinib, Ceritinib, Lorlatinib, and the most recently developed Repotrectinib. Particular Repotrectinib has a response rate of 100% in TKI-naive patients and 75% in pretreated patients. Entrectinib is about 55% in 11 patients, so small cohort. Duration of response 12.9 months. Lorlatinib about 67%. Duration of response 50% in TKI-naive. And pretreated is response rate 53%, 6 months, duration of response 60%. So now the last kid on the block. KRAS mutation are the second most frequent mutation in non-small cell lung cancer. However, for several decades, there were several attempts to target these mutations, in particular the KRAS G12C mutation. And finally, now we have a very good inhibitor that is currently under FDA review for approval. So the KRAS is a GTP binding protein that links receptor tyrosine kinase activation to intracellular signaling. Mutation of KRAS favors the GTP bound active state here in this cartoon and constitutive activation of downstream's effect. So the particular KRAS G12C mutation has been identified as an oncogenic driver of tumorigenesis and is found in approximately 13% of lung cancer. So this new inhibitor, which is called, as a name, Sotorasib, is Amgen 510, is a first-in-class small molecule that specifically and irreversibly inhibits KRAS G12C mutation by locking in its inactive GDP bound state. Other drugs that specifically target these mutations are currently in development. For example, this is the J&J 746-99157, the Mirati 849, and then the Genentech GDC 6036. So in non-small cell lung cancer, so it was the cohort 59 patients, basically. The response rate was 32%. This is in the efficacy of Sotorasib in all types of tumor in the clinical trial that was published recently by Dr. Hong in New England Journal of Medicine. And you see here, partial responses were 19 out of 59, so 32%. Disease control rate was 88%. This was the non-small cell lung cancer cohort, which showed the most promising results compared to the colorectal cancer and other histology cohorts. So this is the waterfall plot that shows that actually responses in the were found in all cohorts, different dose cohorts, like 180 milligram, which is the orange one. You see there are some responses. Then 360 milligram is in yellow, and you have light blue in 720 milligram and 960 milligram, which was actually the one that showed the dose that showed the highest number of responses. This is a vignette that shows a non-small cell lung cancer case in which there is a significant response in the mediastinal lymph nodes, and actual responses have been recorded to happen very, very quickly. So this is the swimmer plot, and you see the color-coded different responses. So orange is the lowest, the doses. The orange is 180 milligram, and we have yellow 360, light blue 720, and dark blue 960 milligram. And these are all non-small cell lung cancer patients. Then we have the spider plot here showing that significant number of responses in all those cohorts. And this is the median progression free survival 6.3 months. This is progression-free survival curve. As you can see, these are pretreated patients, of course. The safety profile, so we have, it's a drug that requires some monitoring and attention, as all of them, but some serious adverse events, grade 3 and 4, especially for basically diarrhea, fatigue. We have some abdominal pain, anemia, LFTs increase, arthralgias are among the ones that have the highest grade of toxicity. So at this point, I'm going to stop because I think I'm running out of time, and I'll be happy to accept and respond to your questions. Thank you.